Welcome to the Living Chronic Special Series, Military, Medicine, and the Mission Left Behind. In this powerful series, we're taking a hard, unflinching look at the cracks in the systems meant to care for those who serve. We'll examine the deep cuts to the military health system and how they're impacting service members, retirees, and military families. We'll talk about the VA, what's working, what's not, and the looming threats of cuts and privatization. We'll tackle the tough topics others often avoid: suicide, PTSD, gaps in care, and the devastating ways veterans and families are being left behind. You'll hear real stories, learn how to advocate for yourself and your loved ones, and understand the unique challenges faced by military and veteran communities. Our mission is simple: shine a light, spark change, and fight for the care and dignity our service members and their families have earned. We'll return to our regular Living Chronic content soon, but right now, if you've served or if you know someone who has, please share this series. Together, we can push for real change and make a real difference in the lives of those who've sacrificed so much. This is Brandy Schantz, and you're listening to Living Chronic. We're here in our special series, Military Veterans, Medicine, and the Mission Left Behind. Today I'm here with Helen Perry, our special featured guest for this series. Helen is an Army veteran, nurse practitioner. She has worked within the military health system extensively and has a lot of really great knowledge. She's also a caregiver to her husband, a wounded warrior. So welcome, Helen. Thank you so much. I'm really excited because I know you have so much great information on the military health system.
Absolutely. Happy to be here and share my very unique perspective on what is probably a more complicated system than it needs to be.
Well, they're all complicated systems, as we've talked about, but trying to kind of sift through all of this and understand it as best we can is so important. I first met you through the NPR article you were featured in, talking about the cuts to the military health system and what that meant for you and your husband, who is dealing with a great illness. He has traumatic brain injury, dealing with seizures, in addition to some other illnesses. So medical care is obviously very important to your family. It is to all of our families. And those cuts in the military health system really had a huge effect. I read that article and it immediately hit me and resonated with me in so many ways, not only because I myself have been a victim of dramatic cuts to the military health system, but also because we're hearing so much right now about privatizing VA care, and everybody thinks that sounds great. Private sounds wonderful. It must be amazing health care, except we're sitting on proof that it doesn't work. And that article really did a great job of explaining why. So tell me a little bit about how those cuts to the military health system affected you and your family.
Yeah. So, I think first, the thing that people kind of have to understand is that when we talk about the military health system, we are talking about, there's multiple components of it. So probably first, what people think of is the Veterans Administration. The VA provides care to qualified, eligible veterans. It's qualified and eligible are not the same thing. And so you need to make sure that people understand that it's not everybody can just go in and get care. And so the VA is one component of military and veteran healthcare system. Then you have the MHS, and the MHS is sort of thought as TRICARE, which is the military health insurance that you get when you are an active duty service member, a reservist, or you are retired and qualified under your retirement with at least a 30% rating on the DoD side of your military retirement, right? Most people don't understand there's a DoD rating that you get, and there's a VA rating that you get, and those are not the same thing. So if you qualify under your military retirement, then you are eligible for TRICARE. And TRICARE is that private insurance that covers then civilian medical care out in the community or community care at military treatment facilities. The MHS is sort of generally thought of as those military treatment facilities and the care that they provide at hospitals like Walter Reed and San Antonio Military Medical Center, or Balboa, different places like that, the healthcare on base around the country. And it gets to be complicated because there's a lot of components to it that people kind of don't understand. And so I'm going to just give some background, which is the military healthcare system really has three primary functions. The first function is to have a ready medical force in the event that we have a war, that we have doctors and nurses and lab techs and x-ray technicians and corpsmen and medics who are ready and capable to deploy to a war at the drop of a hat. Right? These are field hospitals. These are forward surgical teams. These are all of the things that we need to put into a war at a moment's notice to provide healthcare, both traumatic and acute, and also long-term and just basic primary care to keep military members healthy so that they can fight in wars for the military. The second purpose of having a military health system is to maintain a ready medical force. So that is to keep our soldiers healthy and to make sure that they are capable of deploying in war, right? So that's all of the healthcare that they get at home. And the third component is to provide healthcare for our military families and our retirees. And we are currently failing at all three of those things. Because what has happened and what people don't know is that the budget that covers the workload of the MHS, so the budget that covers paying for the doctors, that pays for the nurses, both the military nurses and the civilian nurses, that covers the contracts for services, the housekeeping that comes in, all of those things, those budgets have been hacked away significantly over the course of the last really 10 years. And I was actually on active duty when this started. And I felt so crazy because I would be like, I feel like this is a terrible idea. Like, what do you mean it's cheaper to send somebody out into the civilian world than it is to provide care for them here, especially when like these services have to exist anyways? And my leadership told me that that was out of my lane and to keep my mouth shut and to stop, asking questions. And I just didn't stop. And I just continued to ask a lot of questions. And now here I am, and I know way more about it than I should. But basically, so we had a couple of things happen. First, we had the base realignment and closure. So BRAC happens, right? We started closing military bases. And also we started looking at closing military hospitals because Congress came back and said, sort of in the 2011, 2013 timeframe, Congress said, military medicine is costing too much money and we need to hack that back. Well, that was also during the peak of Iraq and Afghanistan. And it turns out when you blow up a bunch of people in war, they're very expensive to put back together. So I don't really know what to tell Congress, but maybe don't start wars if you don't want to pay for them would be the first thing I would say. But what they started doing was they started looking at the military health system and they started doing some studies of the military health system and how much does it cost to run this system. And you can actually look these studies up. There was a 2013 study that was put out, and it was the military modernization study in healthcare. I think that was the 2013, so there was the military modernization report that was done in 2015, and then there was the MHS modernization study that was done in 2013. And you can go and read those many hundreds of pages as I have. But what you will find is a bunch of kind of nonsense. And I mean that lovingly to the people who wrote them. But as somebody who works in the military healthcare system or who had worked in the military healthcare system, there were egregious flaws in this study that even me as a basic nurse at the time could pick out of excuse me, that's not applicable to us. Because basically what they tried to do was take equivalents between the military healthcare system and the civilian healthcare system and then compare them cost to cost. But those things aren't the same. Let me give you an example. Civilian pediatricians don't deploy to Afghanistan, but military pediatricians do. And they have to have a very different subset of training to do that compared to civilian physicians. Similarly, orthopedic surgeons and orthopedic trauma surgeons on the military healthcare system have to have a level of training in blast trauma and prosthetics and things like hypertrophic ossification and all of these other things that civilian hospitals are not going to have. And civilian hospitals are going to have a significantly higher proportion of people who get sort of these let's refer to them as like luxury services, joint
Right.
injections, knee replacements that like maybe aren't needed.
Right.
These sort of elective procedures that bill really high and make them a lot of money, but
Hmm.
don't really cost their clinics that much time. So these are like very high reimbursing procedures as compared to the military health system and their orthopedic trauma surgeons, which are going to be seeing a lot of blast amputations, which are very labor
Hmm.
intensive and don't reimburse that much money. In fact, reimbursement really isn't a thing on the military healthcare system because they're not like billing in the same way that the civilian side is, right? So there's all this inequity in these studies. And then based on those studies, they decided to cut funding for the military health system. And and what that has equated to over the years is that we have lost a significant number of doctors and nurses and contract staff at these hospitals. And many of these clinics and hospitals are now closing completely because they
Hmm.
don't have the specialty staff that they need. They don't have the nurses to run the operations. And because they've done this realignment under the DHA to basically say, hey, we don't need services in this area. So what all does that mean? That's a lot of like background, but like what that actually
Yeah.
means for people is that if you are somebody who is qualified to use the military health system, either you're a military member, you are a family member, or you are an eligible retiree, it means that you have a harder time accessing care through the MHS than you ever have before.
Hmm.
And so, for example, I have case reports from families who are stationed at West Point in New York who cannot find the clinic up there lost their pediatrician. So they had to drive into New York City to find a pediatrician that accepted TRICARE. You have people, the Abilene, Texas primary care clinic was closed by the DHA under this realignment and was turned
Hmm.
into an occupational health clinic, meaning they would only see people for work-related exposures. So all of the families in that area were now basically forced into the community to find primary care pediatricians, get their blood work done, all of their basic care while they're stationed in Abilene, which is not necessarily the most robust healthcare system out there.
Right.
And then now they're just expected to like go into the community and figure it out. And so what it means is it's a significant limit in our service members and their families and our retirees' ability to access care because that's really just not an option anymore. And actually, most of the military treatment facilities, so you're talking about big hospitals, at all the different areas, like they've all basically said, well, now our priority is only active duty service members, first active duty service
Yeah.
members, then their families, then retirees. And so they have this
Yeah.
priority list. And it's this huge double-edged sword because what happens is they're not now that these hospitals and these clinics are not seeing sort of a wide variety of patients, the skill set of those providers becomes very, very narrow. And then the
Hmm.
DHA, the Defense Health Administration, says, well, they're not keeping up their skills. They're not seeing, they're not doing enough of these other procedures. This was a whole debate that went on.
Yeah.
For example, in San Antonio, years ago, there was a concern that the cardiothoracic surgeons in San Antonio were not doing enough open heart surgeries. Those patients, because of the war, because of all these other things, the open heart surgeries were all being referred out into the community. And they said, well, these cardiothoracic surgeons are not maintaining the skill. And it's like, true, but those cardiothoracic surgeons are also doing a significant number of penetrating chest traumas, which is not
Hmm.
something that a lot of civilian cardiothoracic surgeons are getting round the clock. So
Hmm.
we're not really comparing apples to apples when we're looking at the civilian health system versus the military health system and its ability to provide services. And it really negatively impacts, especially our military, their readiness, and then our military families' ability to access
Yeah.
care.
And I think it's important to point out that the civilian community and Congress knows this very well when it comes to, let's say, for example, in the DC metro area, there was recently a Maryland police officer who was run over by a young driver intentionally, and he lost a leg. One of the first things that Maryland did was request special access to Walter Reed. Why?
Because they have
Who can help somebody
yeah,
who's lost a leg?
yeah,
Walter Reed.
yeah.
So we know that these specialized surgeons and orthopedic specialists are there for a very good reason, and people are more than ready to use them and recognize the importance of that specialty when needed.
Right. But they have to fund it and keep it going.
Yeah.
And that's where I think a lot of people, it's not just funding. It's funding that's done through NDAA. I think the other really important thing to notice is that, so this has been going on for 10, 20-ish years now, right? That these programs, that the military health system has been cut back and been defunding. To kind of give you an example, the military health system, like in 2020, cut about 18,000 uniformed medical billets. 18,000 uniform medical billets. Those are doctors, nurses that are just gone. Like they just don't exist. Yes. So then how do we fill that? Well, we got to use a contract, or we just don't replace them. If we don't replace them, that means that we don't have nurses in clinics. We don't have doctors in hospitals. We don't have doctors in clinics, right? So these things are just, poof, gone. And so, it's, 50 military treatment facilities that they've designated as either downsizing or closing. They've had all of these changes, as we've, gone through this quote realignment, which I hate that term because it's just been, it's defunding, right? It's decapitating is what it is.
And for those of us who reside in the policy world, the years of 2011 to 2013, there was a very similar tone to today's policy. We were talking BRAC, we were talking sequestration back then. It was all about saving money, but essentially what happened were a lot of things were defunded.
Yes. And
that's where a lot of this is coming from.
The defunding is where we have kind of ended up. And it's, interestingly enough, so like that was done in sort of 11, 13 kind of time frame. In 2020, it became so apparent that these cuts were just egregiously harming our military families, and our veterans, that Congress actually asked for and put an injunction to these changes. They said, please stop everything. Please stop what you are doing completely. This is so terrible. Please stop. But it's still been going on. The realignment is still taking place and it's still happening today. And it's continuing to hurt our families, but now there's sort of a different political agenda that's impacting it, with money being moved to support other things. And, that's a whole other conversation. But the bottom line is, when people are talking about, we support veterans, we support our troops, we support our veterans, all of these kinds of things. Thank you for your service, right? It's very hard to say that while you're simultaneously defunding the programs that support healthcare for our military families.
Yes.
That support programs that support our military families. And so then people will say, well, if the military treatment facilities don't exist, then let's just use TRICARE. They can just use their TRICARE. They can go off post, right? Well, Here's the problem with that. TRICARE is one of the lowest reimbursing insurances out there to date. And in fact, there are multiple instances that it is very well documented that TRICARE reimburses less than Medicaid, which is very, very low.
Very low.
Very low. And people will come back and they say, no, they can't. There's a law that prevents them from doing that. And my retort to that is, you're right. There is, but that does not stop them. And in order to fight that, a healthcare clinic has to have an attorney. They have to have billing experts. They have to have forensic billing experts who then take them to court. There's arbitration agreements that they have to go through. There's it is not just you write a letter that says, hey, you can't do this, and you shake your finger and then suddenly they pay you the right amount. That doesn't happen. And to give you an example of how bad this is, I have, through the advocacy work that I do with patients and families, I have explanations of benefits that have been shown to me where TRICARE has reimbursed 30 cents, right, for a 1-hour mental health appointment. How do you run a business? How do you pay your employees, right?
Yeah, you can't.
You can't. And then now there's the whole debacle with the Tri-West takeover, where we had East, there's people don't know this, but there's TRICARE West and there's TRICARE East, and there used to be other TRICAREs. But they've basically made TRICARE West and TRICARE East now, but then they keep debating like who gets which states in the middle. And so they swap back and forth. But when
Oh
everything
my
changed to
goodness.
Tri West and those states moved over, billing and reimbursement to medical providers essentially stopped. And what that means is that for months and months and months, and this is still ongoing, I know healthcare clinics that have
Yeah.
not been reimbursed by TRICARE for greater than 6 months, that the checks just stopped coming.
Yep.
And what that meant for medical providers is that they had to stop seeing TRICARE patients.
Yeah.
And that may not sound like a huge deal, but if you are somebody who has a chronic disease, if you have a child who has special needs, if you have a child in ABA therapy, if you have somebody in speech therapy, occupational therapy, mental health support,
Yeah.
you suddenly cannot see the provider that maybe you've been established with for years.
Yep.
You can't get your prescriptions refilled. You can't do anything. And this didn't just happen to a couple dozen. This happened to
No, it was
hundreds, if not thousands of people across the country that they're
at
providers.
one point, I'm standing in a line at Walgreens trying to get my prescription. And I'm one of, I think that day there were 6 of us TRICARE, and which is hilarious. I live in the DC metro area. This isn't, we're not,
Yeah.
I'm not in Fort Bragg, North Carolina, where everybody's associated with the military. Now here there were, it's like 6 of us, all of us on phones. Why are you denying? They kept telling us that we had other health care.
Yeah.
No, we don't.
Yeah.
You are our insurance.
Yep.
And, then we were exchanging stories. Have you had appointments canceled? Yep, I have too. My doctor says they're not getting reimbursements, so they just had to cancel all appointments. So I don't get to see my doctor. So here we are standing in line at the Walgreens, all of us trying to figure out where to get our health care and how to get our prescriptions because it was so much of a debacle.
Yeah. And it's still ongoing. There are still providers out there who are not getting paid. For anybody who doesn't know, there was a billing issue when everybody changed from TRICARE East to TRICARE West. You had to update your billing information with TRICARE West to make sure that you weren't kicked off the program. Except that problem has been acknowledged now and exceptions have been made. However, I think it's July 21st. I'd have to go back and look at the specific date, but that exception is going to be terminated. And if you don't have a payment method on file, they will cancel your access to TRICARE. And if you don't know, to get it back, you have to back pay the entire amount. So even if you weren't using TRICARE for those number of months and you weren't eligible because they had canceled your plan, you would still have to back pay the full amount. So you need to go on, if you are a TRICARE West person, even if you're a TRICARE East person, just go on and make sure they have your updated billing information on file to make sure that you continue to get your services. Because unfortunately with TRICARE, it doesn't matter how right you are and how many times, you as the patient or the family did the right thing. If they say it is that way, it is that way. And you will be the one to bear the cost. And so that's, it's this evolving problem of how do people manage, with the military health system and how do we fix it? I think another part of this that a lot of people don't consider is, again, going back to like the thank you for your service and we support our military. When we don't have a ready medical force to deploy and to provide services in the event of a war, that means that more service members die.
Yes.
They suffer more catastrophic injuries and they die. And I think everybody can agree that that is a horrible notion to consider, but that is the reality. And, one of the other jobs that I do is that I work in humanitarian aid. I specifically work overseas in war and conflicted areas. And so I am intimately familiar with the health impact of war and what war does to militaries, to civilians, to people in general. And if you look at like what's happening in Ukraine would be an example of like what we would consider sort of a large scale combat operations, LCSOs. And that's what always the military is talking about. That's what the Pentagon is talking about. Our ability to intervene on a medical front, in large scale combat operations. Right now, Ukraine is taking about 100 critically, catastrophically wounded patients a day out of the East. That varies. It waxes and wanes depending on, what operations are happening and all this. That's just a rough ballpark number. If we were doing that today, we would run out of beds in the military health system within like a month.
Mm-hmm.
And that's not even considering that most of those patients need intensive care beds, right? So that requires intensive care nurses, that requires surgical intensivist doctors, the total military health system I have to look at, I think has like 3,000. I have to look it up because I keep forgetting. But basically, we would run out of beds in less than a month at that rate.
And that's catastrophic.
Yeah.
That's catastrophic.
Yeah. I mean, and then people say, oh, well, put them in the civilian health system. And you say, but when we do that, we know that active duty service members actually have worse outcomes because
yes,
the civilian healthcare system is not well versed at caring for blast trauma. They're not well versed at caring for blast induced or overpressure induced traumatic brain injuries. They're not well versed at caring for multiple gunshot wounds. And they said, oh, but you could send them to one of these trauma centers that does that. And you would say, yeah, but they have limited bed capacity also.
Yes.
So it's not that
everybody's overworked.
Exactly. And not only that,
overworked.
So one of the things that I've been tracking with these changes to the military health system and to TRICARE is sort of what's happening to service members as they need to access their care in the military, in the civilian community. And one of the things that we've been noticing is, again, we've talked about this before, the civilian healthcare infrastructure is not healthy, right? It's overworked, it's understaffed, it's under-resourced. So even on the civilian side, people are waiting 6 and 8 weeks. I mean, for me in a busy area of Florida, it is not uncommon to wait 6 months for a referral, for an acute referral for a specialist. Sometimes less, sometimes more if you can kind of work some magic. But let's even say that it's 3 months, right? Let's just say that an active duty service member can get a referral into the community and get seen in 3 months by a civilian provider. Well, the problem is there are actually policies that dictate how long an active duty service member can be on a profile before they have to undergo a medical evaluation board or a physical evaluation board and be looked at for medical retirement and be found fit or unfit. And the problem is that the way in which the civilian sector does their coding and billing. So coding is basically, we have this thing called ICD-10. It's basically these big alphanumeric system where we say you have a sprained ankle without complication. And that is, I can't even remember. I don't even do these codes. It's S93.40, unspecified sprain of a ligament of the ankle, right?
Mm-hmm.
Well, if you have a complication to that, then you might be billing extra of like S93.4009D, which is like subsequent encounters. Or other codes that you're using because those codes have to then match like the reimbursement, like if you're putting in CPT codes for joint injections or things like that. And on the civilian side, there are certain codes that have to match for like physical therapy. So like you see a doctor for this sprained ankle, you need physical therapy. So that physical therapy is going to be an additional charge, an additional valuation, like those numbers and letters, those codes have to match the thing that you get billed for.
Mm-hmm.
On the military healthcare side, on the MHS side, like they just refer you to physical therapy and they have access standard of care policies about how quickly you have to be seen if you're a service member. That does not exist on the outside.
Right. They're not going to rush you through because you're
they aren't. Yeah, like best of luck to you. You go in the same queue as everybody else. And oh, by the way, you have insurance that doesn't pay very well. So who do you think they're going to see first? Somebody whose insurance pays really, really well or somebody whose insurance pays crap? So now you were in this queue. So let's say you have this sprained ankle. It took you 3 months to see the specialist. You finally see the specialist. He says, yeah, you need physical therapy. You go into physical therapy. You got to wait 3 months to get your physical therapy. So now you're at 6 months. So then you do 3 months of physical therapy, right? Now you've been on profile for 9 months. And you have to get off profile by the 1 year mark where it's a mandatory. It's different in the different services, but years sort of generally. Some services it's actually 9 months, others it's a year. But even before that, if you're repeatedly put on extended profile, they can actually put you in a physical evade. And this is for a sprained ankle.
Yes. And, for those who don't serve in the military, readiness is always top priority.
Right.
Military readiness. We are there to be ready, we're trained, ready, healthy, ready to go when the nation needs us.
Right.
And if you have service members in a rotation of 9 months for simple ankle sprain,
Right.
you're losing readiness by the day.
Right.
So it's hurting our ability to be able to respond to a war situation.
Right. And it's also losing.
And that's very important.
Yeah, it's losing us qualified service members because now so many of them are being automatically referred into this, oh, you're not fit, you can't serve. So they're being kicked out based on this medical, and they really have not been afforded the opportunity to get to have the ability or the time that they need just based on sheer timeline of the system. That's not even looking at people who actually undergoes, serious accidents. I'm aware of a patient who had a femur fracture. It was just this freak accident while she was out doing, she was bicycling and crashed a bike, and like not a big deal, but she was highly, 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 highly qualified. There's like 5 of her in the country. And the military started to process her out because she just couldn't get access to resources, to the medical services she needed to rehab and recover. And because we have cut down, if we would have been looking at her ability to access services 10 years ago, if we had a fully staffed medical health system, military health system, this never would have happened. Right. So what's happening is that service members are actually getting forced out of the military. Some people are okay with it. Some people are not. Based on their inability to access care and being put out into the military health system or into the civilian health system, and it's creating problems. And the same is true for our military families. So many of them now, when they're getting stationed, especially at the remote bases, they have children who have exceptional needs. Maybe they have an autistic child or a child who's deaf or blind, or has some additional need, and then you get stationed and whatever. And they have programs, right? Like the Exceptional Family Medical Program, EFMP, and like all of these other, programs that exist. But the problem is that those programs aren't actually looking to see if providers in those areas are actually accepting health TRICARE. So they'll say, oh, there's an audiologist in South Dakota. And you're like, yeah, there is, but they don't accept TRICARE, or they're a 5-hour drive away.
Right.
Right. And there's this assumption that, well, your spouse could just take care of that. And it's like, that's not how this works. That's not how engaged parents. And
well, it's interesting to me, for the military folks listening, or people who have served in the military, it's always interesting to me how in the year, here we are, 2025, even when I was in years ago, they perpetually exist in a world where there is this spousal figure whose just full-time job it is to take care of all of the nonsense that may ever come your way. Yeah. And we were both, obviously both women in the Army, female officers. So many of us are married to other military members. And I would always say, so which one of us gets to be the spouse? Which one of us gets to just not go to work because we're going to take care of all the nonsense that you want to just throw out at us? Because I'm here to tell you, there is no magical stay-at-home spouse that just does all of the things. This isn't 1952. Yeah. There is not this expectation that you're going to get married and have a stay-at-home wife to just do things.
That expectation.
And, oh, by the way,
if we wanted you to have a spouse, we would have issued you one. That nonsense.
Issued you one.
Yeah.
Well, it's obviously you wanted me to have one because you keep telling me to make this spouse person take care of all these things that are absolutely ridiculous.
Absolutely. I will put in sort of a shameless plug for my friend's book. And if people really want to understand the intricacies of what happens to service members when they get injured and how the system is just sort of set up to fail. My friend Carrie Fugate wrote a book called Alive Day. It's a memoir of her experience being a young wife and marrying a Marine who was injured in Iraq and then subsequently died because of his injuries. And it covers a lot of other, issues that she dealt with personally. But it's very specifically, as someone who went through this with a spouse who was wounded in Afghanistan, I will say that it touched on so many of the failures of the systems that exist within the military health system. And I mean that to be the MHS, the VA, TRICARE, everything, the way the system is built, and sort of the pressure that we put on families as caregivers, and this understanding and expectation that if you are injured, that it will be a family member who just magically shows up to take on, a lot of, yeah. And people don't understand, people, don't really appreciate this, but like, so my husband, with his traumatic brain injury, with his epilepsy, his memory loss, his aphasia, all of these things, I am a highly trained nurse practitioner. I'm dual board certified. I can't work full time anymore because I'm doing about 30 hours a week of case management, just case management for him. That's not even like the actual medical care that I provide to him,
Right.
Issuing medications, supervising instruction, making sure he's safe, all of these things. That's just case management. That's referral coordination. Yes. That's, filling prescriptions. That's making sure that all of these things are done. And if it were not for me, he would have died. I will give you an example of so the other day I was telling him he should take Zofran, which is a medication for nausea. He was confusing it with Ativan, which is a sedative medication. He thought I was telling him to take 4 milligrams of Ativan, which is a very high dose, versus 4 milligrams of Zofran, which is like a standard dose. And that is something that could have potentially ended his life. Right? Like he needs, and that is where caregivers are so instrumental. And yet in the military health system and in the VA system, we are still struggling to get acknowledgement of the role that families play in keeping service members healthy, and keeping veterans healthy, and keeping disabled veterans healthy, or as healthy as can be. Yes. And it's, it is such a struggle as an advocate to explain to people, we do have the caregiver program now on the VA side. But it's, it is a program, again, that's not being funded to the extent that it needs to be, to make sure that we have caregivers, out there to provide for our families. And so it's, again, the military health system is not something that a lot of people think about when we think about, we like support our troops. And it's like, no, like, yes, we support our troops, but like also please fund the things that they need to exist. And that is the MHS.
It's one thing to say, I support the troops. It's an entirely different thing to say, what can I do to support the troops? Because that's a better question.
Right.
It's not just simply, I support the troops. Ask yourself, how can I support the troops? Okay, well, then let's talk. Let's talk about increasing funding for military health systems, for our active duty troops, for our families, for our retired, eligible TRICARE service members. Let's talk about funding the VA, plussing up our services there. Let's talk about caregivers. Let's talk about quality of life. Everybody wants to say the words, be aware of, veteran suicide. I could post something about 21 a day or something about veteran suicide on social media, and it would get thousands and thousands, millions probably of shares, and everybody's going to love it. But what about, let's talk about why veterans commit suicide? That's a harder conversation, because now we're talking about quality of life.
Right.
What's our quality of life? It's not simply having somebody call us from the VA, from the suicide hotline, and say, hey, I'm Mike and I'm a combat veteran too. No, it's, what have you done to improve my quality of life now that I'm a disabled veteran?
Well, and I think too, I know that I have talked to so many veterans and family members who are going through these extreme circumstances, these challenges medically, right? Whatever it may be, right? Mm-hmm. And the systems are so broken, and they feel crazy. They feel right. There's a name for that. It's called hypernormalization. If you're not aware of it, look it up. It's where a broken system is made to seem like, oh, this is just totally normal. It's you. You are the problem.
It's just the way it is.
It's just the way it is. You are the problem, right? And we have all
you have to learn the bureaucracy.
Yes. And I have experienced it. I have experienced it as a healthcare provider. I have been gaslit by doctors, by nurses. I mean, trust me, like, we all experience it. But I think the challenge for veterans is they get to a point where, and especially their family members, where they're like, they throw their hands up in there and they're like, my God, maybe it is me. Maybe I am the problem. Maybe I am crazy. Right. And it's this, And then it's this spiral from there, because these things are
Yes.
actually happening to them, whatever it may be, whether it's psychological, whether it's physical, it doesn't matter. But these things,
Combination
all
often.
right. And these things are happening, and they start spiraling and spiraling and spiraling. And then it affects their job. It affects their
Hmm.
finances. It affects their ability to have a quality of life. It affects their ability to actually seek healthcare, to get out of the situation that got them there in the first place. And then when
Yes.
that starts to crumble, then it affects their relationships. It affects their relationships with their children. Their cars get repoed. Like, it's just this catastrophic spiral that happens to so many families. And then when they do desperate things in an act of desperation, because no one has been able to just point them in a direction to say, hey, here's how we can fix this. Then we
Yes.
go, oh my God, why? And
Yeah.
nobody wants to go back and look at all of the things that have happened and that has happened to the family, right? And
Yes.
to that caregiver and that spouse or that significant other, or whoever it may be, a brother, a sister, a mother, father, whoever, who has been screaming about access to services for however many months or years. And then everybody goes, oh my God, 22 a day? It's terrible. But nobody wants to fund the programs. I just saw a note that the
Yeah.
suicide crisis hotline was simultaneously doing multiple calls at the same time. Can you imagine
I can. Yeah.
calling and then being like, please hold, and you're like,
Yeah.
I'm this person in crisis and you want to like take another call? Like,
Just take another call, please hold.
yeah,
And you're right. And it goes back to where were the different points of failure leading up to that phone call?
yeah,
Where were the different points of failure? I have told my own story multiple times. First of all, one of the things that makes my care more difficult is I now suffer from medical trauma.
mm-hmm.
And I didn't know it was a thing until I was dead in the middle of it. And now I have these triggers, and I go in and you try to throw me into a different bureaucracy, make me jump over a different hoop. And who knows? Sometimes I can't even tell you what the trigger is, but I am now spiraling and I'm out of it and I can't do it. I don't want to do it anymore. I'm done with you. I'm walking out. I'm screaming. I'm melting down. I'm any one of these things, which makes things more difficult. But at one point, I was having severe migraines that were making me throw up. I couldn't walk. I couldn't see. I was, I was getting aura. It was horrific. And I'm going to the ER for these migraines, and they're just giving me a migraine cocktail, sending me home. It was terrible. And I'm just trying to get my doctor at the VA to prescribe me migraine meds and get them to my house ASAP. And he mistakenly called me via his cell phone once and said, oh, well, what am I doing? And I'm like, I don't even know what's going on at the VA that you've mistakenly called me from your cell phone and didn't know. He forgot to put in that prescription. I tried calling the clinic. There's no direct line to the neurology clinic there.
Yeah.
So I wasn't getting anybody. I left about 40 messages. I just could not get a doctor to call me in a simple script. And this lasted 2 weeks, and I'm in tears and I'm in pain, and I just can't take it anymore. And I finally got a hold of somebody in the hospital that was not neurology, but there's no line to neurology, but I'm having a complete meltdown. So I'm like, somebody's just got to help me. You just got to help me. I'm in so much pain. I can't see. You've got to help me. And I'm in tears, and who knows what happened in that meltdown, but apparently it was bad. And I just slammed down the phone and just was laying on the couch with my ice packs on my head. And my husband's there trying to just soothe me as best he can. And then we got a knock on the door, and it was the police.
Yeah.
The VA wanted to do a medical check on me. And that's what kicked off about the 10 a day calls from the veteran suicide hotline to me. And I said, you know what I needed other than a check from the cops or 10 calls a day from the veteran suicide hotline?
A script for triptan. Yeah. Like
just a triptan, guys.
Yeah. And
problem solved.
Think about, veterans who have, especially on the TBI side, so many veterans have traumatic brain injuries. They do have complex mental health conditions. Yes. And then they go into crisis and they go into this spiral, and family members. I mean, God, I can't tell you how many emails and messages I get about, how do I reach this provider? Oh my God, he's spiraling. We don't have a crisis plan. Right. So many veterans I've talked to, I'm like, do you have a crisis plan? And they're like, the emergency department. And I'm like, oh, please, please, please. First of all, for mental health, especially, the emergency room is probably if you have to go, you have to go. But that is not the best place. right? Like
No.
that is not an excuse. That is not the solution to every problem. And so we send people to emergency departments. And if you are someone who has ever been in a mental health crisis and gone to an ER, you will probably attest to this, that is probably not the best place for them to be.
Right.
And so then we go, oh gosh, I just don't know. I don't understand. And it's like, well, how did we not? Like, how did we not see this coming? And it's, I've even said this, I am blessed in that I was medically trained when I started this journey with my husband. So I started from a level much higher than most spouses. But as a spouse of somebody who is especially combat wounded, you are thrown into it like you are expected to like manage them and keep them alive. Like it's on you. And they make
That's your job.
Yeah, it's your job. They make it very clear. And,
Yes.
I was blessed that I had medical training and I kind of knew how to do that. But I think about how so many families don't have that. And God, the number of times that I have said, I just want somebody to freaking help me. I just want somebody to field a phone call to help coordinate testing and appointments and, test results and referrals. God, I just want some help. And I'll never forget talking to a VA case manager who said, when I was begging for help, and she said, he's not going to get any better. This is your new normal. You need to get used to it. And I was like,
Thank you.
Thank you. Thank you for that pearl of wisdom, ma'am. Like, you're still not helping me in the problem that I have right now, which is I need help. We need help. And I mean, they did nothing for us. I mean, they didn't end up helping with us. And that has led me to the realization so many times of like, I'm in this on my own. Nobody's coming to help us. No one's coming to save us.
And you shouldn't be.
We shouldn't be.
I think,
we shouldn't be.
You should be.
I'm sorry, I'm yelling
None
on your
of us should be.
podcast, but like
That's what this podcast is for. We yell, we scream, we cry, we get mad. It's also, it's a hard life.
We wonder why so many veterans have mismanagement in their care. Because, I am smart enough to know, through my medical training and master's degrees and all of this, right? I have the background and the education to know that anytime he's prescribed a new medication, I need to compare it with his other list of meds to make sure that that there's not a reaction, that isn't great polypharmacy. There's also very specific things with his meds, like certain of his medication has to be timed very, very specifically with food and when he can eat after taking the medication or before taking the medication and what types of food he can eat. And if you're just a lay person who's not medically trained and no one's ever explained to you the importance of this,
and they don't,
you just are like, oh, grapefruit juice, no bigs. Why?
We just don't have grapefruit juice in my house anymore. I feel like that's just a good, for anybody taking medication.
But I'll tell you one that most people don't think about, and that's THC and CBD oil.
Oh.
So CBD oil and THC very specifically work on the same compound and the same molecule that most of your drugs are metabolized through. And so if you can look this up, but THC will then interact with that as like a CYP450 inhibitor, which basically means it can't metabolize the medication the way that it should. So if you're taking a medication who utilizes the CYP450 enzyme to process it, and then you are using THC or CBD oil and it interferes, then you are going to get lower drug concentrations than you should. This particularly can affect seizure patients and diabetics. So we have a lot of patients, like I see patients all the time in the hospital that are regular THC users, and many veterans are. Absolutely zero judgment of that. Like, I'm not saying don't.
No, and there's certain cases where it's useful.
Not saying don't use it. What I'm saying is if you are somebody who takes certain medication and you do use THC or CBD oil, you need to time it with your medication so that they're at least 2 hours apart. And that's
good info.
That's like all you got to do. So like I see in the patient, in the hospital, all these patients having breakthrough seizures, and they're like, but I take my medication. And I'm like, yeah, but like, when are you using your THC? How are you using it and what concentrations? You're using THC at the same time you take your medication because you use it to sleep at night. Well, that's probably why your blood concentrations are so much lower of this, medication that you're taking is because of this. That's not saying don't use it. It's just saying you just need a little education to say,
I just need to understand.
Take it at a different time.
And all of these things could, be better done for us if we did have that funding. And that's a lot of what, today's about. We have so many great episodes in this special we're doing. We're going to talk about veteran suicide and and, how we actually improve quality of life and caregivers and how we better help caregivers. But the bottom line is we can't do any of these things unless these programs are funded.
Money. It's money.
So we need them to be funded, get focused.
Yeah.
So, we need to talk about this. And I think, why I wanted to start with talking about the military health system is because right now, so there's a lot of, as I mentioned earlier in this episode, there's a lot of similarities between that 2011 to 2013 timeframe of sequestration and BRAC and all these things. And today we're talking about cutting funding for all sorts of things today. It's all about, that kind of this, again, this sequestration type of event where we want to, privatize and move things. But we have a case study right in front of us. The military health system, it's in free fall. And yes, Congress did step in and say, oh, no,
Oops.
What did we do?
Right.
This was bad. But when you have an avalanche coming at you, it's hard to just stop that. It's rolling.
Yeah.
It's coming down. So there's no way to just quickly stop it. So when we start doing the exact same thing to Veterans Affairs healthcare as we've done to the military healthcare system, guess what, folks? We're not going to get a different outcome.
Yeah.
The outcome is not going to be miraculously different cutting VA than it was the military health system. Yeah. And now we have two healthcare systems focused on veterans and military and their families that are in free fall. Yeah. And we just can't let that happen. We cannot say, well, just let it happen and then we'll see if we can't put a little plug into that big, It's not going to happen that way. It's not. We're already suffering greatly.
It is.
So if you want to support our troops,
this is how to do it. You have to fund it. And it's, I think for a lot of people, it's very, we've talked about the funding complexities and all these kinds of things. If you want to support, this level and this particular issue, it's literally just sending an email to your elected officials that says, I think we need to support the military healthcare system fully by funding it appropriately and restoring it to previous levels from prior to the cuts in accordance with the recommendations of Congress, because the Congress has actually already looked into this and decided where it should be. And so just send an email that says hey, I think we should fund this. I think we should stop making cuts to I think we should require TRICARE to reimburse equitably. I think there should.
And you know what? We'll get together. I'll put together, get it out on the website, brandyschantz.com. I can't even pronounce my own name. A sample letter that you can send, and we'll put down everything you need to know. We'll cite the congressional mandates. We'll put in there the years. We'll let you know what to say.
Yep.
We'll get it out there. We'll get it on the website.
And then all you have to do is copy and paste to your representatives. But I can understand for military families, for veteran families, when people come up to us on the street now and they thank me and they thank my husband and, thank you for your service and all these kinds of things. It is difficult to swallow those thanks nowadays, especially when people are also out there openly cheering, cutting these programs that we rely on to keep him alive. And it's, I think a lot of families feel that. I think a lot of families are frustrated at the inability of their loved ones and their veteran loved ones specifically to get access to care. But I think part of that frustration also needs to be for people to start doing the research and understanding why is it happening and why can't I access care? Why? Where have we gone off the rails? So that we as a nation can really start living up to the commitments that we've made, because the deal was that if you serve, your family gets health care, you get health care, and if you are injured, they will take care of you. Yes. That's the deal. That's the deal we all signed on to. And that's not happening. That's not happening for active duty service members. It's not happening for their families. It's not happening for our veterans. And that's where I think people are getting really frustrated. And I think that's why our retention numbers are so low. That's why our recruitment numbers are low. And for people who say but we're not in a war right now. We have more deployed forces that we have today than we have even during peak. Could we have more overseas missions that are running? We still have people in Syria. We still have people deploying into areas, near Israel. We still have people going off the coast in the South Pacific. We have all of these operations that are happening. And so we are still getting service members and then just like the day-to-day stuff, how many airborne guys, God, I saw a static line drag, and the Department of the Army, like posted a thing and was like, he's okay. And I was like, no, he's not.
No, he's not.
I was like, he had like a 30-second line drag when doing a static jump. And I was like, no. I was like, there is no way that he walked away from this without back pain. Like, come on, please,
He's not okay,
yeah,
guys.
I just, like these things happen, and we need to be able to provide, healthcare for our families and our service members and our veterans.
No, absolutely. Absolutely. And it's, again, we've said this before, you're going to hear this on the series quite a bit. It's only getting worse. Yeah. And all of these things in different healthcare systems are interconnected. And you have these active duty military service members in areas where, they've cut back on the military healthcare system, so they can't get care on post. So then they go off post, except these are, especially the Army and the Air Force too, has a lot. The Navy, you know what? Those guys are on the coast.
I know,
they luck out in so many ways. They got a nice little spot. We're stuck in rural areas. The most, my husband always said, well, if you're in the Army, you're going to the armpits of America. They're rural, they're poor. They are poverty stricken. The wealthiest person in town is always the general.
Yeah. And I'll give you an example.
That's your wealthy guy in town.
I'll give you an example of this. If you think about Georgia as a state, Georgia has 13 military bases throughout the state, right? 63 counties in Georgia don't have a pediatrician. 78 counties in Georgia don't have an OBGYN. So if you have a military base who cuts pediatricians or cuts OBGYNs, which many of them did,
where are you going to have your
Where are you going to go? And how are you going to get care? You're just going to take them to the emergency room, or you're going to drive hours and hours and hours to get to some place that does. Yes. We'll talk about the financial cost of that and gas, the time cost, the cost of to your job with lost work hours if your significant other works. This isn't that's just one example. This is happening all over the country. And then people say like, oh, well, maybe that doesn't affect veterans. Well, veterans get pregnant. Veterans have families, right? And so it's, that's just one sort of glaring, example of why we need a robust military health system, especially in these rural areas where we can't actually provide for military families who are going there.
Exactly. And these areas experience more cuts, the harder it's going to be for military members and their families. And yes, just like we said, that's the promise. Yeah. Promise made, make it a promise kept.
Yeah, exactly.
You should be providing medical care for the service members and their families. There's no reason that a service member or their family member should have to drive 2 states over to give birth to a child. Yeah. But that's what happens today.
Oh, absolutely. And that's if they can find, I know that in many places in the United States, now we're getting to this thing called obstetrical deserts where we don't actually have OBGYNs. Yes. Many patients are being advised to just show up in the emergency room when they go into labor. Yep. That is horrible on so many different levels. And the other thing I will say, I continue to say this over and over and over. If you are a military member or a veteran or a family of a military member or a veteran, and you are having difficulties accessing care, if you're just having challenges, if you just don't like the way that it functions, right? If you don't like the cost you're paying in copays, if you don't like the cost you're paying in prescriptions, if you don't like the fact that now TRICARE has a co-insurance, if you don't like any of these things, please, please, please be writing your elected officials to say, hey, like this is not the promise that we made. I vividly remember during a 2012-2013 congressional hearing that they had where it was repeatedly touted that service members who were combat wounded would not experience an increase in their cost of care as these changes were being implemented. And I have to tell you that our copays have gone up every single year. And we pay more and more a month to where now we're paying between $1,200 and $1,500 in out-of-pocket costs per month to provide for my husband's care. So like, that was not true. They said these things and they have not kept up with it. And that is a travesty, right? We've made these promises. Like I said, the deal was if we served, we got these things, they need to live up to that now.
And there's no wounded warrior in this nation who should be spending $1,500 a month out of pocket for their care.
Period. And listen, people will say all sorts of things. They'll say, oh, you should just drive to the base. Well, I would love to. That's an hour and 45 minutes away. And by the way, they won't see us because we're not on a priority status because they have decrease their staffing because of this
Yes.
realignment. And they'll say, well, then you should use the VA. And I'd say, I would love to. They don't have the providers to see us either.
Yeah.
So like, what do you want us to do? I'm sorry that he's complicated. I'm sorry that they blew him up in Afghanistan, right? Trust me, I would have rather him had an amputation than the traumatic brain injury. We could have gotten a prosthetic and moved on years ago. But like the
Right.
reality is it's never simple. These patients do have complex care needs. And if you can't get care, then you're stuck paying out of pocket for it. And we are incredibly blessed that we can afford that cost and that we are making it work, but we shouldn't have to.
Yeah.
And that's, I think, where people get the messaging lost is they're like, oh, but you have TRICARE, you have the MHS, you have the VA, like you can, and it's like, no, it's not, it doesn't work that way. And especially when none of those things have money, you know,
Yes.
for example, if we were to use the military health system and the military health system were to decide like, oh, well, at Naval Hospital, Jacksonville, if we were being seen and he needed to go to say Walter Reed, which happened a few years ago, because he's combat wounded, that care and that travel should be covered under a specific pot of funds that the Navy has available to combat wounded veterans. Only it didn't have any money. So when he got referred to Walter Reed, we had to pay out of pocket, and we were extraordinarily blessed that a nonprofit stepped up to help cover some of those costs for us. But otherwise, we
Yes.
were left paying thousands of dollars for airfare and
Yes.
hotels and all of these things. And it's like,
Sitters, if you don't, you
yeah,
don't have child
yeah,
care.
exactly. I mean, it's, oh man, don't even get me started on the childcare thing. The
Yep.
VA, the military health system, none of it is built to be friendly to families that have small children. I have a huge problem with the fact that VAs do not have a child safe or child friendly waiting areas. Like that is, and I'll have them tell me all the time, like, just bring them with you. And I'm like, I'm sorry. Have you ever had a 4 and a 2-year-old? Like, absolutely no. Like, like that's just not appropriate, especially if you don't have a child friendly space,
Yes.
it just, none of these systems are built to support families who have small children. And so, for active duty service members, especially, I have said, we were blessed to have our children after we both left active duty. I don't know how we would have done it. Like, I just truly don't.
Yeah.
I just truly don't, especially, one of our children has some special needs and, that keeps our hands very full. I don't know how families are doing it, especially when their access to care is so incredibly limited.
They're breaking.
They're breaking and they're leaving.
Breaking.
And you know what? Service members, rightfully so, are choosing their families over service.
Yes.
And they're getting out.
Yes.
And in fact, I did a FOIA request years ago, and a Freedom of Information request. I asked the Department of Defense, I said, how many service members between the ranks of from E6 and above are leaving service because of situations incompatible, because of caregiving situations? So either they have become a caregiver to a child, a parent, a spouse, whoever. And it was like 23,000 over the course of 10 years.
That's amazing.
Specifically that reason, 23,000, E6 and above. You want to talk about how much money it costs to train an E6
Yes.
and above, like officers who have been through, you're talking about, I think I also looked at captains and above. I had sort of excluded people who had only been in the service like 1 or 2 years. It was like 23,000 people specific to caregiving issues, because we don't have policies in the military to support families that sufficiently support them with exceptional medical needs.
That's right.
And so, like, how can we be surprised? You have a child who's born with a genetic condition or with a chronic illness, or you have a loved one who develops a chronic illness, you have a parent who gets sick, whatever it may be. How do you survive? If you're still being required to do these things. I know that we went through that. It was a major reason why I left active duty, was because they could not support me as a caregiver to my husband, and that we couldn't get him the services that he needed. So it's all of these things of like, this is why we need people to really put their money where their mouth is when they say they support the troops. Is we need you to be writing elected officials to say, hey, fund these programs appropriately so our families can have access to care.
Absolutely. And again, I'll be sure to have that on my website. I'll be sure to put as much information as I can in the show notes, because get involved, get involved. We're not going to make this better. We're not going to help veterans and military service members until we do something about it. And that goes with just be an advocate.
Yeah.
And that just sometimes means just copy and paste the recommended email we put out. Make a quick phone call if you're in DC, make a quick visit to your representative's office, do whatever you can, but we have to do something.
Absolutely. And I will also put this out for, if you're a military veteran or you're a veteran, you're struggling to get care, part of what I do as an advocate is help people navigate that. Because I'm a nurse practitioner and I'm sort of well versed in all of these things. A lot of times I can just have a quick conversation to help. I can't give you medical advice, but I can just point you in a right direction to say, oh, okay, here's how we solve that problem. And it just sometimes makes it easier for families to get on the right path so they don't end up in these incredibly frustrating situations. So, I'm happy to help facilitate that for people who need it.
Mm-hmm.
If you just need a direction to go in, we can figure out how people can reach out to me and we can, facilitate that for them. Because it is, it's the only way we all get through this is through community. It's
No, absolutely. Absolutely. Thank you so much. I mean, we could probably go on and on about this topic, but again, that's why we have a whole series. Be sure to stay tuned to the whole series. We have a lot of great topics that we're talking about, a lot of great information, a lot of great insight, recommendations, tips, tricks, you name it. We're going over it all. So thank you for listening. This is Living Chronic. That's a wrap for this episode of Living Chronic. I hope today's conversation gave you insight, inspiration, or at least a little reassurance that you're not alone on this journey. Living with a chronic illness or disability comes with its challenges, but it also comes with strength, resilience, and a community that understands. If you enjoyed today's episode, be sure to subscribe, leave a review, and share it with someone who might need to hear it. You could follow me on Instagram at Chronically Brandy Schantz, other socials at Brandy Schantz, or my website at brandyschantz.com for more discussions, advocacy updates, and everyday strategies for thriving with a chronic illness. And if you have a topic you'd like to hear about, send me a message. I'd love to hear from you. Until next time, keep pushing forward, keep advocating for yourself, and remember, you are more than your diagnosis. You are powerful. You are unstoppable. Thanks for listening to Living Chronic. See you next time.